Hello, good afternoon, everybody. Thanks for joining us on our webinar today. The topic we have today is our recently launched guidance on how we want to support care at home providers to take action to meet the pressure ulcer prevention and management standards. So on our call this afternoon, my name is Joyce Murray. I'm a Senior Improvement Advisor with the Health and Social Care Improvement Team. And if we move on to the next slide, we'll see our other speakers who are Jamie McNabb, who's the lead nurse with care homes and care at home at NHS Highland, and one of our inspectors, Jane Blair, who works in our complaints team. And we've also got Jenny Ross, our team's improvement support officer, who's going to be our technical support for this afternoon. So moving on, just a few housekeeping points. We've got the session for around an hour and a half. If we finish early, that's good, but we will finish on time. We will be recording the session this afternoon, and we've got closed captions functions for subtitles if you need that. You can use the chat function to ask any questions during the presentations, but we've switched microphones and cameras off, so that protects our connection so we don't have minimal technical difficulties. We've got a Q&A session at the end for any discussion and questions that are in the chat, and the slides and recording will be sent out after the webinar. Nearer the end of the session, Jenny will pop an evaluation form into the chat, so I'd appreciate if people would take the time to give us some feedback. And there is a couple of comments coming up saying that people are not hearing. Does that help? Can everybody hear now? Okay, that's great. So just moving on to our next slide, getting the thumbs up now, so that's good. So this is the standards that we're here to talk about this afternoon, and these were refreshed in October 2020. They do cover both health and social care, which include care at home and care homes, which are specifically mentioned. And the Care Inspectorate supported the development of these standards and will use them to support inspection and complaints. Moving on to our next slide, we just wanted to have a chat around why pressure ulcers matter to care at home services and staff. And you can see these pictures here, pretty graphic, but that's the stark reality when a person's skin starts to break down. And we know that skin breakdown can go from the stage 1 red area to stage 3 or 4, where there's extensive damage very quickly. And the person who is perhaps unwell, not eating and drinking, immobile, has continence issues. So this can happen, as I say, very, very, very quickly. And if it's not picked up, it can escalate to quite a serious, deep wound. So the client group that you're caring for as care at home providers are usually older adults with increasing frailty, physical disability or sensory impairment. So they're the most likely people to develop a pressure ulcer. So looking at our next slide about the impact that it has on the person. So the impact on the individual is immense. We know that pressure ulcers can be life-threatening. They can also lead to severe disabilities, amputation in some cases, if it's a foot ulcer. Also infection, osteomyelitis. The person might need to be admitted to hospital when they might have an extended hospital stay because of complications around their pressure ulcer. They may need surgery. There's also the chance that they will be immobile for prolonged periods of time. They might need to be confined to bed, etc. So it does have a great impact on the quality of people's lives, and just as important, they might not be able, to be active, go out, join in their usual social activities during this time or after their recovery. They'll also have the district nurse or another professional coming in to do their dressings. And we know that some people won't leave their house because of the exudate, leaking dressings, and possible malodor. And, people are embarrassed around that. Most importantly, it can cause pain and suffering. So there's a lot of things wrapped up in that for the individual who develops a pressure ulcer. So moving on to our next slide. This is about the financial impact, and apologies, this is an old slide. I'm sure these costs are much, much higher, but it's just to illustrate that there are financial implications both for the NHS and for the care at home service as well. So we start with increased dependency and care and support for the person. They'll need, their care will take longer. This might have an impact on the length of care at home visits, and also staff skills to recognise when there's a deterioration in the person or their skin or their pressure ulcer or, their general overall condition. They're also, from the NHS perspective, the GP and district nurse, podiatry, tissue viability, there's a lot of professionals that might be involved around care and support for that person's needs. There'll be prescribing costs, frequent visits from the district nurse or podiatry, whoever's doing the dressings. And the other aspect is that there is also the threat of complaints and increasing litigation to the NHS or the care at home service as well, because as you as the care provider, you also have a duty of care for that person. So moving on to our next slide, the care inspectorate were aware over the pandemic that there was a rise in people experiencing home care, developing pressure ulcers. And we knew that through our notification data, but also our complaints data as well. So our chief inspector and other staff were involved in some large-scale investigations across the country at that time around people developing pressure ulcers, which were quite serious and life-threatening in some cases. So Marie Patterson, our chief inspector, asked me to do a piece of work around raising awareness about pressure ulcer standards and care and support with care at home services. So early last year, we had a collaborative event with health and social care professionals round the table. We introduced the healthcare improvement standards for prevention and management of pressure ulcers to the audience. And the aim was to try and explore with them which areas they felt were appropriate, for a care at home service, because you don't provide care over a 24-hour period. So there would be some of the content of these standards which were not appropriate or applicable to care at home. So we had a Jamboard session, and the next slide shows us our 4 Jamboard questions. And we really wanted to explore what current practice was for care at home workers. And that was around identifying and monitoring skin changes, and also looking after people who have an existing pressure ulcer. We also wanted to hear about the challenges for care at home providers and workers, and also the overview of the care standards, what they felt they needed to do next. So from that set of questions, we analysed the data, and there were quite a number of post-its posted on the Jamboard, and there was quite a lot of discussion at the end of the session. But there were some key areas, if we can move to the next slide, please. There were some key areas and themes that kept coming up. So we got the feeling that there was pockets of good practice already happening, but these were not consistent across Scotland. They were things around skin checks were happening, but not always recorded or acted on. And it was quite clear that providers didn't have a policy or a standard operating procedure for staff around skin care or preventing pressure ulcers. Some areas had a policy, but felt they needed to look at that against, the information that's held in the standards. There was also issues around communication and escalation pathways. A lot of staff weren't clear about how to escalate any concerns or who to escalate these to. These hadn't been particularly formalised in certain parts of the country. And there was also some difficulties with communication with healthcare professionals, and GP practices were highlighted as well. So managing people with an existing pressure ulcer or other wounds, it was also flagged up that there's, in some cases, the care at home workers are looking after people who have a diabetic foot ulcer or a leg ulcer. So there's quite a number of wounds that you come across in your day-to-day work. So when things went a wee bit wrong, staff were not sure if they could apply a simple dressing as a temporary measure when a dressing fell off, and others were just advised to leave the wound open until the district nurse could attend. So again, that's not really good or consistent practice. There were also issues highlighted about some people don't always comply or want to do what is advised to them about maybe having periods of bed rest, keeping their legs elevated, or mobilising more. So there's lots of things around that were highlighted as well. There was also the time was highlighted, and that sometimes carers felt they were pressured. They didn't have enough time to carry out all the care and support that a person with a wound or had a pressure ulcer prevention plan might need. And there was also some discussion around training, and it was agreed that the sector needed more input around knowledge and understanding of skin breakdown, and especially recognising early damage around that. So moving on to our evaluation, one of the key things that came out of our evaluation was Jane, our inspector, gave a presentation of a complaint that she had been involved in, and some of the feedback around that was that people didn't really understand or appreciate how quickly skin can break down and how quickly things can go wrong and have a detrimental impact on the person. So I'm now going to hand over to Jane, who's going to share with us the case story about what happened to a person experiencing care. So Jane, hi, thank you for joining us today. You just want to do a quick introduction and
good afternoon.
That would be great.
Yeah, my name is Jane Blair. I'm a complaint inspector with the National Complaints Team at the Care Inspectorate. And my presentation is really just an overview of what we found that was happening in the care at home sector, particular to pressure care. How quickly things can go wrong and how quickly skin can break down and a pressure ulcer can develop. And the kind of contributing factors specific to care at home and how these might be avoided. So if we move on to the first slide. So it's really a case study where things had gone particularly wrong and particularly tragic for this family. So we receive complaints when people experience poor health and care outcomes. So we can receive complaints from family members or from other healthcare professionals. And these include a wide range of issues, but what we've found is that they're becoming increasingly more complex for care at home services. And people being supported at home may experience inconsistent and unstable care provision and staffing, significant time restraints, and poor communication between health and social care professionals. Just the next slide, please. So Mr. Smith's background was that the background of the complaint was that Mr. Smith's wife logged a complaint with us following his passing. and we'd agreed to investigate how the service promoted and managed his skin integrity. He received 4 visits a day to support him with personal incontinence care. His wife provided the support in between those times. He was diagnosed with diabetes, dementia, and bilateral leg amputation. So immediately we could see the risks for Mr. Smith, skin breakdown and developing a pressure ulcer. Next slide. He had recently returned home from hospital where he had underwent surgery to amputate his remaining leg. And prior to this, he'd actually been quite ambulant with his one leg, and he could independently transfer from chair to bed and vice versa using a banana board. The district nurses were there every other day to monitor his post-surgery recovery. He could no longer access the upper floor of his house, and he chose to sleep in his armchair on the lower floor where all care and support was provided while he was in this armchair. So next slide. During this time, he experienced a loss of appetite and weight loss. He was no longer mobile. He had both urinary and fecal incontinence. He had extremely low mood, cognitive decline, and his surgical wound was not healing well. And of course, the increased pain from that. In the care notes, there were sporadic reports of redness and breaks in his skin in the sacral area. He was later admitted to hospital and diagnosed with sepsis, and it was thought this was a result of infection of a grade 4 pressure ulcer, and he passed away some days later. So if we move on to our findings of the investigation on the next slide. So on return from hospital, Mr. Smith's needs were not reassessed by either the district nurses or the care at home service. It was business as usual, even though he'd had significant surgery. And the risk of him developing a pressure ulcer was not assessed by either party. It was not recorded in the personal support plan. The risks of the change in needs and the risks were not recorded in the personal support plan. And it made no reference at all to staff monitoring his skin and application of prescribed creams. The records of care did not consistently record changes in the condition of Mr. Smith's skin or the application of prescribed creams. Next slide, please. The district nurses were not consulted with or informed of the development of a pressure ulcer. Staff had not been provided with specific pressure care training, and the organisation did not have a policy relating to promotion of skin integrity. Next slide, please. So as a result of our investigation, unfortunately, this provider was given a requirement to make improvements to their well, certainly the prevention of pressure ulcers, and also to have training and a policy in place to prevent this from happening again. It was a very sad case, and very tragic for Mr. Smith's family. That's it. Thank you. Thank you for your time.
Thanks, Jane. That's great. Thanks for sharing that with us. And the reason we wanted to share that was just to show you the common themes that our complaints team are finding, and the trajectory of how quickly a person's skin can break down and things can, unravel quite rapidly. So we don't want to be pointing the finger and blaming anybody, but again, it's just the sort of overview of this to be able to understand the complexities of these situations. So moving on to our next slide, back to our collaborative event, the outcome of that discussion and the questions that we asked and the evaluations that came back was that there was a good appetite to support some guidance in the sector and to support developing policy and practice around preventing pressure ulcers. So our next steps were to set up a small provider group to discuss and have a look at how we could develop some meaningful guidance. So these were 8 services from across Scotland, all providing a very different approach to their service. So it was interesting to hear everybody's perspective. So we looked at each standard individually and extrapolated all the information that we felt was appropriate for a care at home service, and we felt it was good to just keep it in the format of what each standard meant for care at home. And then we decided that we would test the guidance out. So these 8 services took the guidance away, and we had feedback with several tweaks, and information resources were added. So the final version is what we published recently. And the key themes that came out of it, there was only 2. One was where a provider had a policy, and I think 3 of the participating 8 did have a policy in place, but they felt it helped them self-evaluate what they had, which they felt there were bits missing, and it helped them to, make their policy better. And for the 5 remaining services, they didn't have a policy, so they felt it greatly helped them to draft out what they felt their needs were around the standards. So we now have the launched guidance, and our aim of our webinar today is just to have this overview and conversation around what each of the standards mean, and to try and help you guys to understand what needs to be put in place and how to take action around that. So moving on to our next slide, we've got the standards. We've got 7 particular standards. Not all of them, or not all of the content of each of these standards, as I said, will be appropriate. So we'll just work through each standard and discuss the key points. So moving on to standard 1, which is leadership and governance. So the aim of this standard would be for the care at home service to have a policy in place. It would be the same as any other policy you have, for example, infection prevention and control. It's about what you want your staff to do, a clear outline of their roles and responsibilities in preventing pressure ulcers. And as I said, each care at home organisation will be different and will have different components of these standards as part of their policy. So the standards say it's good to have a lead person for skin care and prevention, and that would be based on the size of your care at home service. It might, if you're a standalone service, it might be the manager or the deputy, or if you're a larger provider, it might be your quality or improvement person or your trainer. So again, that's very much down to the size of the organisation. The other area that came across through our Jamboard questions was that not all of the clients who are referred for care at home there's a discussion around their level of risk of developing skin breakdown. So what their Waterloo or Braden score is that is coming either from the district nurse or the hospital. So that care at home services weren't always getting told the level of risk of the person. So again, that's a good point always to think about as part of new referrals and assessments. Also, the referral and escalation routes. It's good that staff are clear on how to act if they find a person who has pressure damage or any skin issues, and it could be reporting it to the team manager, or it may be directly to the district nurse, the health centre, etc. So again, it's good to have clarity around that. So there are some documentation attached to pressure ulcer prevention. Obviously, the risk assessments that are carried out by health professionals. For example, I've mentioned the Waterloo, but there's also documentation that's particularly relevant to a care at home provider and staff around assessment, care planning and evaluation. And we'll talk a wee bit more about that in the slides coming up. The other area is there's always, when things go wrong, it's always good to look back and reflect and have some internal discussion about, key things that happened, and also involvement in wider reviews. I mentioned these large-scale investigations, and NHS colleagues always have to report a pressure ulcer via their DTICs, and there's always some form of investigation or discussion, around how that happened. And it's not, again, as I said, it's not about blaming people, it's about learning and improvement and taking these things forward. So moving on to slide, next slide, please, standard 2. This is around staff education and training, and we've asked Jamie to come along this afternoon to talk about that. She's quite heavily involved with her care home and care at home services up in Highland around pressure ulcer prevention. So I'm not going to go into much detail around this, but just to say from the care inspector viewpoint, our inspectors will look at training records and will look for pressure ulcer prevention, skin care training, etc. And Jamie will go more into the content of that. So it's again about any area of training that it's recorded, that staff receive induction training, refresher training, etc. And there's also the issue around use of equipment or aids. So if the person has a pressure reducing mattress, aid mattress, it's good that staff know how that works, that they get involved in the local training around that, and the settings in particular for that that person, if it's based on their weight, etc., or if they go in and the mattress is alarming, that they know who to escalate that to, or how to troubleshoot that. So these things are all important around the day-to-day care for that person. So as I said, Jamie will cover that in much more detail around the content of training. So moving on to the next slide, standard 3, person-centred information. And this is aimed at the person experiencing care and making sure that they're informed and understand about skin care, pressure damage, etc., and what's happening to them and what they should expect. So there are plenty of leaflets and information. We've signposted in the guidance to some links around Healthcare Improvement Scotland have a patient information leaflet. There's other local areas might have developed their own. You as a provider might want to develop a fact sheet or a one page on, this is happening and this is what you should expect, and how your home care workers will look after you. So again, that's a pretty simple thing to meet, and there's already some existing samples around. So standard 4 in our next slide. As I said, it's one of the key things is important to have the information about the person's level of risk and specific care needs, and getting that from the referring agency. So that helps you inform your care plan for the person, and we talk about care planning under the relevant standard there. So you also need to carry out an initial assessment and get your baseline information around the person, and the ongoing monitoring. And we'll talk at the next slide about tools that are appropriate for care at home. We're not expecting care at home workers to do Waterloo or Braden or anything like that, but there are some tools around that would support staff to monitor and pick up on any changes in the person's condition. And again, that escalation route, if there is any changes, that staff are clear around how to act and get help as quickly as possible. We know that if the person gets the care and support they need at the time, then that can minimise skin damage, and dressings, equipment being put in place as soon as possible is really helpful around that. On equipment as well, we've mentioned that it's a crucial part of preventing or making the person comfortable. So again, a delay in getting any equipment for that person or any advice, again, the care workers should be documenting that and making sure that that's escalated to the right person. So moving on to our next slide, standard 5 is about the regular reassessment of the person and the ongoing monitoring. I mentioned tools appropriate for care at home. So in our guidance, we've signposted you to the preliminary pressure ulcer risk assessment tool, which is on Healthcare Improvements Tissue Viability Toolkit. And it looks at 3 simple areas: nutrition, continence and mobility. So again, that's a pretty simple tool to apply. Any changes in these 3 areas would make the alarm bell ring, and that would be something that the carer would want to document in the care plan, but also report and escalate that as well. I've recently been made aware of the Pressure Ulcer Prevention 5-question tool, which we're going to add the link in to the guidance around that. It's a bit more sophisticated. It looks at mobility, continence, nutrition, the person's skin, and also using the carer's judgment around should this, be a red flag or not. So again, this tool would be a helpful aid for carers at each visit. Again, how often should we be doing these things? And it's down to you as the provider to make these decisions, looking at perhaps every visit or daily, depending on the person's condition, or if they have an existing pressure ulcer, or you're looking at preventing pressure ulcers. So again, these things are down to professional judgment. The other resource that Jamie's going to talk about as well is our eyes and ears. Again, the Care Inspectorate developed that as a prompt to remind staff of the key areas they should be looking for during a visit to a person. So clear actions for carers. We want people to be, checking skin on a regular basis. Early detection and escalation is good. The quicker you get the person the care and support they need, minimises any further damage. And again, looking at equipment, we've covered that already, that carers know how to act if a piece of equipment is malfunctioning, or alarming, or it breaks down. So again, there's all these things to take into account. And I think that's something that when we did get the feedback from our Jamboard questions, equipment was one of the kind of areas that frightened staff. So giving them the knowledge around how these pieces of equipment work, and knowing the settings, etc., is quite useful in allaying these fears for staff. So moving on again to our next standard, and slide 6, care planning for prevention. And I know that you'll have person-centred care plans in place, but it's good to focus on that preventative approach, and including all information from the healthcare professionals involved, as well as the care staff. There's also skincare regimes and products. Sometimes we jump to the preventing pressure ulcers without thinking about the day-to-day skincare for that person. What they wash themselves with, what emollients or moisturizers they need, and how to apply these. So again, that's part of the individual person-centered plan. So one of the questions that we discussed within the development stage was what a good care plan looks like for prevention. So in our next slide, that is a slide that we pulled, or information we pulled together for people to consider, care planning for that person based on their level of risk, if their skin is intact or they've got an existing pressure ulcer. So again, it's around the frequency of the skin checks and being quite explicit about that, and encouraging the person to be mobile where they can, or assisting them with repositioning if that's necessary, looking at their continence care, nutrition, hydration, and also their skin care regime, as I've mentioned. Equipment again comes into it, and also the implementation of this. And I know our inspectors say that they see lovely care plans written, but not all of the, the care plan is implemented. So, the implementation of this is important in maintaining people's skin integrity. Review or evaluation timescales are also important. And again, if things change, there needs to be, a review of the person's level of risk, having that discussion with healthcare colleagues, and making sure that the care plans are changed to meet people's needs. So our last standard is assessment, grading and care planning for people with identified pressure ulcers. So once a person develops a pressure ulcer, the prevention plan still needs to continue, because obviously they're vulnerable, and other areas of skin might start to break down. So again, it's the staff role would be, that early detection and escalation of any further skin damage. Knowing what for part of the training, one of the key components for me is to, know what that red area means. And again, I don't want to encroach on Jamie's presentation, but as well as pressure damage, there could also be moisture damage. So again, knowing the difference between the two of them. The Scottish Social Services Council's SSC app is very useful for care at home workers, and we want to highlight that just to make sure that folks are aware of that. And also, again, this escalation pathway for people with existing ulcers, that it is still important to be maintaining skin checks on a regular basis and recording and escalating this. The other area was unexpected events, when dressings fall off, or the carers go in and the dressing's either contaminated with body fluids, or there's leakage escaping from it. And there was a bit of anxiety again around that. And there were varying methods of dealing with this. Some care at home staff were instructed to contact the district nurse right away and leave the dressing open, which is not good practice. It could get contaminated, causing infection, etc. And others were advised to put a simple dry dressing, on top of it until the district nurse could come in and dress it again properly. So again, I think that there needs to be some clarity for staff around how to deal with these situations. And the other area was staff recognising when there might be a wound infection. So again, that can be reported. So looking at, the wound, there's more exudate, the dressing might be coming off, the person might be more confused, to have a temperature, etc. So again, for care at home workers to recognise these signs and symptoms is quite crucial. And the other area was that, the providers discussed that when these things happen, family or the person themselves get quite anxious and uptight about this. And it's good that, the carer has a clear pathway to follow, so that they know how to manage the situation, get advice and get the right treatment, and, bring people's anxiety levels down. Okay, so that's us covered most all of the standards, and I'm going to, just before I hand over to Jamie, we've been talking for 40 minutes now, so I'm not seeing any questions in the chat. So if people want to pop their questions in the chat, or any areas for discussion, but also just we've been inactive for 40 minutes. So if everybody could try and move around and have a wee comfort, relieve your pressure, etc. I'm standing, so I'm okay. I'm jogging about from one foot to the other, but just to practice what we're preaching here. So I'm now going to hand you over to Jamie. So welcome, Jamie.
Hi, thank you. So I'm Jamie, and as Joyce said, I'm the lead nurse for care homes and care at home in NHS Highland. If you can go to the next slide, please. So keen today just to use this opportunity to make sure that we're all understanding the importance of the risk assessment and the risk reduction in our care planning. A little bit about how to undertake a skin assessment and how to document our findings, how to escalate concerns, understanding the principles of good skincare, and then thinking about signposting other educational opportunities to support yourself and your teams. Next slide, please. So as Joyce mentioned with the standards, when you go on the Health Improvement Scotland website and you open this and you see that it's a really big document, please don't worry. Each standard is really clearly broken down into people, so those that you care for, the staff, the frontline workers, and then for yourself as an organisation, what that means and what your requirements are. So it's really actually, although it looks like quite a cumbersome document, it's very simple to use. So I'd highly recommend having a read through that. Next slide, please. So it's really important that we're aware of what causes skin breakdown. So the four main causes of skin breakdown is pressure. So pressure being a continuous physical force exerted on or against an object by something it's in contact with. So any of you who are sitting just now in your chair, thinking about how the bony bits of your bottom and your pelvis feel on that chair, that's pressure. So then thinking about shear, which is a parallel force, and it occurs when the deep skin layers and the bone move away from the upper skin layers. So if you think if somebody was kind of slid up a bed with bad moving and handling technique or not using a slide sheet, then there's going to be that parallel force where the deep skin layers are separated from the other layers. And then thinking about friction. So that's when skin rubs against another surface and it can develop pressure ulcers by causing the skin to separate and then cause a blister. Really common for people who may have conditions that increases movement, for example, Huntington's or Parkinson's. So really key that we're looking out for that. And then finally, moisture associated damage. So it's a broad spectrum of damage. It's essentially any skin damage caused due to prolonged exposure to any source of moisture. So it could be urine, it could be stools, it could be perspiration, it could be wound exudate, it could be mucus, could be saliva, but any damage caused by moisture would fall into that category. Next slide, please. So when we think about our risk factors, if you think about the individuals that your services look after, many of them will already have these intrinsic people factors. So thinking about people who may have poor nutritional states, maybe older, experiencing cognitive impairment or neurological disorders, or having sensory impairment, stroke, diabetes, and thinking about incontinence, infection, medication, or reduced mobility. So all these factors increase the risk of going on to develop a pressure ulcer. On top of that, we've got our external factors. So that could be restricted mobility, thinking about devices, so people who are in casts, wraps, with appliances, catheter straps, moving and handling techniques, microclimate from moisture, or people who have challenges with self-neglect or poor personal hygiene. So, having these in your mind when you think about the individuals who may need care plans in relation to pressure area care is really key, as it will generally be most of the individuals in your care. Next slide, please. So thinking about reducing risk, the most important thing is the staff, frontline staff, being confident talking about this to individuals. So it's really key that they're able to share hints and tips with the individual themselves or with their family, their informal carers, other people who are in the home. So I have got a link later in the slides to show you the patient information leaflet, which is available. But it's really handy, and it just goes through the kind of very basics of pressure area prevention, and can be useful for staff to even keep a few copies in the car that they can hand over to families or individuals if that becomes relevant. So with care at home, the people who are in the house, they're our eyes and ears, and they're likely to be able to spot what's going on. So it's being confident at kind of just reviewing the environment, thinking about footstools, blankets, glasses, hearing aids, medical devices, all these things can increase the risk of pressure damage. And if it's something that we can adapt how somebody's using it, or make a change, then that is really important that people feel empowered to do that. Giving good advice. So often we'll tell people to elevate their legs, and we'll see them perched just on the very bottoms of their heels on a footstool. We want the biggest area possible on a footstool when we're elevating legs. So that should be up under people's calves and really distributing that pressure equally. Thinking about glasses and hearing aids, we can often develop a wee bit of pressure there where they're pressing or uncomfortable for people. So again, it's about supporting people to get back in touch with relevant professionals to address those challenges. So balanced diet, really, really important that people are eating well and are well hydrated to reduce their risk. Promoting mobility and supporting positional changes. So it can, even for people with very, very reduced mobility, there are still things they can do. We can encourage them just to move slightly to one buttock and then to the other, or even lifting one leg and then the other. Each of these little movements just helping to redistribute that pressure throughout the body. And those who are able to change position in bed at night, just reminding them to make sure that they are doing that. Reducing risk, equipment is absolutely key to reducing risk. The challenge, my background is as a community nurse. I know folk don't always want to do what we suggest to them, and we give them equipment and it goes in the cupboard and it isn't necessarily used. And this is the bit again where care at home are absolutely the eyes and ears. So if you know somebody's not using equipment as expected, or maybe not following the instructions they've been given, then it's really worth raising this back to the community nurses, who can often have a bit of a non-concordance discussion with them. And it also allows for that opportunity to document if somebody is choosing not to use the aids suggested, then we've got that paper trail around those decisions. Finally, a regular skin assessment and continence care needs. By meeting those needs and having appropriate care plans, we can further reduce the risk of pressure area breakdown. Next slide, please. So thinking about risk assessments, why do we want to risk assess? We want to reduce the likelihood of developing a pressure ulcer or an existing one deteriorating. And our risk assessment is what's going to inform our care plan. Is this individual at risk? Are they at high risk? Are they at very high risk? So when at first contact with this individual, when you're doing your initial care planning, this is something that would be beneficial. So you may receive information on a discharge letter for someone who's coming out of hospital. Remember that that assessment was undertaken in the hospital in a very controlled environment with very specific equipment. So it may well be that somebody's needs are quite different at home, and just contact the district nursing team to have that reassessed if you feel the assessment that was done in hospital may no longer be accurate. So we recommend recognised tools such as Waterloo and Braden, but the bit that's really important here is clinical judgment, and often it will be your judgment as the people who are in the home and the people who know these individuals best. You'll know what's going on. As a district nurse, we often arranged for people to get beds. Truth of the matter be, they slept in the armchair. And I, as the nurse who got the bed and planned to review them in 12 weeks, may not know that, but you as a carer who goes in and finds them each morning in their armchair will know that. And that kind of information will impact the risk assessment, and in turn will impact what equipment they have. So really, really important that your judgment, your knowledge is shared with other individuals involved in the care. Next slide, please. So thinking about person-centred care planning. So the outcome of your risk assessment and your initial skin inspection should be recorded in that care plan. And we want to look at identifying and managing any risks or contributory factors. So, thinking about what that individual likes to do, if they spend prolonged periods of time in bed, if they have particular risk factors that increase their challenge. We want to be including how frequently this individual should be repositioned. Now, obviously, within a care at home setting, this can be different from the ideal. If someone has 4 visits a day and none overnight, we're not going to be getting 2 hourly, 3 hourly repositioning overnight, and we have to be realistic. However, it is about recording that decision around what has been assessed as their need. Thinking about how often are we going to be inspecting skin. This can become part of everyday care while people are delivering personal care, just making sure they're doing that skin inspection, looking at all areas. And it is really about reminding our teams that it's all pressure areas we need to check. People often just check bottoms when doing personal care, but really thinking about everything: shoulder blades, elbows, heels. We should cross-reference their pressure area care plan with other care plans. It's going to link in with nutrition, it's going to link in with continence care, and it's really important that these work together to support this person in a way that works well for them. Include in that care plan any details of self-management. So include the fact that you've given a patient information leaflet, include the fact that you've spoken to family members about how they can support positional changes, include information that you've shared with the individual around how they can reduce further risks, and plan the frequency of reassessment. Now, when we plan for routine reassessment, we must always think about those things out with the ordinary. So it's that, frequency of reassessment or when something changes. So making sure that we're on it as soon as something changes, somebody becomes unwell, they've maybe gone off their legs, something has changed, we need to get that reassessment done in a timely manner. Next slide, please. So skin inspection. Many areas will use skin bundles, thinking about what that stands for. So it's surface, skin, keep moving, increased moisture, and nutrition. So if we pop to my next slide, please. So thinking about surfaces, it's really important that we have an assessment of the appropriateness of the mattress or the cushions, and we review its functionality and integrity regularly. So staff should be familiar with, when changing a bed or helping someone through to a chair, making sure that cushion or mattress is working properly, that there's no signs of wear and tear, there's no defects that would affect the way it works and the way it reduces pressure damage. For skin inspection, we want to be assessing all pressure areas and monitoring for any skin changes. Keep moving. So that's, assessment of how regularly somebody's able to move themselves, how we're going to support them to move, what assistance we can provide to help with positional changes. Thinking about incontinence and increased moisture. So assessing bowel and bladder function, thinking if this person's got continence products, are they working well for them? Are they not working well for them? Are there other fluids around the skin? As Joyce mentioned, dressings which may have high levels of exudate or be leaking and coming off. All of these things should be included. And then finally, thinking about nutrition, ensuring people have the right diet, adequate fluids, and supplements where they're prescribed. Next slide, please. So when we think about surface in more depth, what are they currently on and do they need a different surface? Do your teams know what to do when they think somebody needs equipment? Are they able to escalate that and access that in a timely fashion? Does all the equipment that's in place work properly? And if there's any damage, that must be reported. Also, when we're checking for damage, if we can build it into the care plan, but every kind of, monthly or 6 weeks, we'd want to see an unzipping of a mattress and looking into the insides, because often what we find is there's no damage on that outer kind of plasticky layer, but there can be damage to the cells within the mattress. So encouraging teams to unzip that, look inside and check for any damage. And really important that we know how to escalate concerns quickly. Thinking also about surfaces, we did a bit of work last year around about cost of living crisis and people who may choose to turn equipment off and the impact that this may have on how well it works. I can't remember the exact figure, but there's a very, very low cost associated with running an airflow mattress. So, making sure teams are able to reassure people that there isn't a high cost with this, and actually turning it off and turning it on each day to save money will likely increase the risk of it malfunctioning. So we would encourage individuals to keep that turned on at all times. Next slide, please. So skin inspection, early inspection means early detection. So encouraging staff to undertake a skin inspection, looking at all these key areas where pressure may be exerted. And what we're looking for change in temperature of skin, we're looking for a change in colour, moisture, a change to the skin's integrity, the elasticity, so if skin's becoming dry and not bouncing back the way it normally would, or any other changes. And if we're spotting those, we want to record them and escalate them. Next slide, please. So keep moving. Positional changes. The ideal position to reduce pressure is the 30-degree recumbent tilt. So you can see from the little picture of the person on the electric bed at the bottom. So that's putting the head end of the bed and the bottom part of the bed up to 30 degrees or less. And that provides maximum contact of body areas to reduce any pressure points. Similarly, we can do that in bed, in a normal bed, using pillows like the little image in the middle. When you're looking after someone who can't change their position themselves, make sure you're recording the position that you're moving them into, left side, right side, onto their back. What is it that we've done when we've changed their position? And making sure we're encouraging individuals to change position between visits wherever possible. Next slide, please. So incontinence and increased moisture. So ensuring that appropriate products are available to manage continence requirements and ensuring that skin is clean and dry, using kind of pH neutral products to cleanse skin and ensuring fully drying before applying any creams or further continence products. Liaising with the community nursing teams or the continence teams early if you recognise that needs are changing for somebody. And it sounds really simple, but promoting the use of the toilet. For many individuals with incontinence, they can have an element of control, be that with their bowels or their bladder. So if we can get someone up and into that seated toileting position on a commode or over the toilet at home, that can help to reduce episodes of incontinence, because when someone is fecally and urine incontinent, the two interact with one another and cause increased damage to the skin. So if we can do anything to reduce the time that incontinence is in touch with the skin, is really helpful. Next slide, please. So nutrition. Helping an individual to eat a healthy, balanced diet and remain well hydrated. If you're noticing somebody's losing weight, thinking about that foods first approach, how do we encourage high calorie, high value diet into an individual who may not be eating as well as normal? Ensuring that a timely referral to dietitian can be made. Care at home staff will be the ones to notice that people's clothes are starting to become loose, or actually the shopping in the fridge isn't going down as quickly as it used to, and making sure that you're able to contact either the community nursing team or dietetics teams directly, depending on your area. And just a little fact for you, there's a significant increased calorie requirement if somebody has a wound. So for an individual with a wound, you need approximately 30 additional calories per kilogram that individual weighs. So it's really quite significant, the amount of calories involved in wound healing. So looking at people with existing wounds, having that high calorie, high protein diet to support them. Next slide, please. So the most important thing that any of your teams can be told is that react to red. Really important that if they're noticing any changes, they must do something. Record it in the notes, but escalate it, because if that has happened, we know that we only have a short window to intervene, to do something different and reduce that person's risk of this breaking down. So we talk about blanching and non-blanching redness. Blanching redness, when you press on it, take your hand away and you see that area of white skin in the middle. This is the earliest warning sign of pressure damage, and ideally that's when we want to react. We want to change something and we want to improve their trajectory by not allowing this to break down further. When it becomes non-blanching, we've actually moved into this being a grade 1 pressure ulcer. So an intact area of skin with redness that doesn't change when you press on it is a grade 1 pressure ulcer, and that's that first stage. We often find this is where the kind of missed opportunity has been between noticing it blanching and non-blanching. So really encourage staff to remember that, react to red. Next slide, please. Skin changes and breakdown can come in many different forms, and I've just put a few up here to share with you. But looking at suspected deep tissue injury, which is the first and the third image there, often we hear staff refer to them as looking like a bruise. So again, I think it's just making sure your teams are aware of what they can look like. In the Health Improvement Scotland link that I have later on, there are charts that show you all the different types of skin damage, moisture and pressure. They're one-page documents. They're really helpful. They've got a brief description, and it might be something that's helpful considering giving to people as part of your induction so they know what they're seeing when they recognise changes. Next slide, please. So escalating concerns, encouraging staff to record their observations. So upon skin inspection, what did I see? And making sure we're recording clearly what we're seeing, where it is, how big it is, as much detail as possible, because that really helps. Inform the senior within your own organisation and link in with the local integrated team, the community nurses, tissue viability GP, whoever it may be that's most appropriate in that setting. And it's really important at that point that you also have a conversation with the individual or their next of kin about their concerns and what can they do in the meantime. The clock's ticking, that redness is there, we need to be making changes straight away. So what can we do to reduce the risk of that deteriorating? Next slide, please. So principles of good skincare is really important. We want all staff to be confident in undertaking skincare for individuals. So first of all, thinking about, our bath oils, our soap substitutes, our ointments, our creams and our lotions. If we look at these little images, if someone has dry skin, it's like the wonky brick wall in the middle here. They're much more at risk of irritants, allergens, skin breakdown. If we're using regular emollients, it just helps to put that top layer on and prevent irritants and allergens being able to penetrate deeper into the skin. With emollients and moisturizers, you can't apply too much. Don't worry. We often see people with the 500-gram pumps of Diprobase that have been in their house for 4 years. Ideally, we want to be getting through one of those fairly quickly if we're applying adequate amounts of emollient to people. Creams should always be applied in the direction of hair growth to reduce any risk of developing folliculitis at the hair follicles. And making sure that barrier creams are fully washed off and areas dried before applying more. Next slide, please. So my last few slides here are just about signposting and where you can find more information. So there's the standards available there, as well as the policy that Jane has spoken through. Next slide, please. And the patient information leaflet, which can be downloaded via that link, and the SSSC app, which is fantastic and has really good images to help people recognise what they're seeing and describe it for notes. So it's a fantastic app. I'd highly recommend encouraging your teams to download that. And the next slide, please. And then thinking about the Care at Home Malnutrition Screening Pack available on the Care Inspectorate's Hub website, and the Care About Physical Activity documents that help us to think about how we increase that movement and decrease that risk of pressure ulcers. Next slide. Thank you. Finally, my last parting shot. The Your Eyes and Ears is a fab resource for individuals, particularly people who are new to home care, and it just goes through that, what prompts can they use when engaging at different parts of the care encounter, and what to absorb, what to observe and report. So thinking particularly in the personal care section around changes to skin, creams and emollients applied, anything that was noticed, and it helps us to have that really holistic view, because the other areas include eating and drinking, going to the toilet, and then thinking about that. What are we doing as we leave? Are there any hazards? Is there anything we need to communicate? So using this as a tool for staff to keep them right on their visits is really helpful. Thank you. You're on mute, Joyce.
Sorry, my mouse is very sensitive today. Yeah, Jamie, thank you very much. That was really very helpful and good overview of care and support for pressure ulcer prevention, and also thanks for signposting to all these useful resources. As Jamie said, some of them are on our hub, and there are some links in the guidance to others as well. So we've got a few questions that we need to have a wee look at. We're at 3:05, so time's okay. We've got Patricia asking, can we obtain a care policy? I've put the link to the policy guidance in the chat to respond to that. And someone's asking why there's not a national policy on pressure ulcers. I think our national policy would be based on the standards. So again, the policy that you develop will be unique to your service that you provide. So there wouldn't be a national policy. I know the Care Inspectorate do have some policy guidance around specific topics, but again, that would be down to the provider to put that in place around their individual service provision. Jane, do you have anything to add to that?
No, as you say, you know, it's about making an individual policy for your organisation and using the guidance for that.
Okay, that's great. The next point was the Braden-Waterlow score. While in acute, this will be usually high due to the nature of admission. It would need to be reviewed and updated on the day of discharge to allow an accurate picture of skin risk. Yeah, I think that's a very relevant point, that sometimes people may be discharged with, you know, a risk score that's not recent or up to date. So that's a good point to bear in mind. The next one's unexpected events. We would be relying on our district nurse partners to provide this information, and I'd be keen to understand how the guidance document has been received by NHS colleagues. I haven't had any feedback. I don't know if there's anybody in the webinar today that's an NHS colleague that might want to put something in the chat. Jamie, you might have some thoughts about this.
I'll pop a little message in the chat.
Okay, thank you. Is there a resource pack we can use for new staff and for staff training? Jane's saying the app would be a good resource, so that's the SSC app, yes. And also Jamie highlighted the You Are Our Eyes and Ears resource. So again, these might be things that you would want to include in your resource pack for new staff. Ruth's asking, is there any literature available that we can use for displays as visual prompts for this subject? Jamie signposted the person information leaflet. I don't know if there's anything else that we could... One of the things I was going to mention at the end was the Society of Tissue Viability have an annual Stop the Pressure Ulcer Week, and this year it's from the 13th to the 17th of November. And we usually put out some information about the events, and they have a week of events and training programs and information. So the Care Inspectorate usually put that out on the provider's update to let providers know around that. And their theme this year is every contact counts. So just, to give you the heads up about that. The copy of the slides, yeah, they'll be sent out. And also, what do you recommend, Waterloo or Braden? I think each of the tools has their merits, but it would be down to the client group and the setting that you're working in. Jamie, do you want to add anything to that?
Yeah, I mean, I think the majority of areas tend to use Waterloo now, but certainly both of them are validated tools that can be used.
Okay, that's great. And we've also highlighted the other tools like the Papura and the 5-question one. Somebody's asking what the app is called and where it might be able to be downloaded. The app is, if you Google or if you go into the SSSC website, you'll find it under their resources. Jamie's put in that she would encourage care at home teams to share the resource with community nursing teams if required. And there's the link for the SSSC app there, which is good. The next question from Anna. This is included in the home care decision making app. Oh, now, Jamie, that's a question for you, I think. Or
I'm
Jane.
not sure if it is in the decision-making app. I think it is. Jane, do you know?
Sorry, no, I'm not sure about that at all.
No, not sure about that at all. Sorry, Patricia. We can maybe find out for you. And Liz and Marie, is there an expectation for the care at home service to complete the Waterloo Braden? From the care inspector viewpoint, no, it would be more one of the simpler assessment tools, like we've put in the Pura and the 5-question one. So I think it would be something like that we would expect you to use to monitor the person's presentation or any changes on a day-to-day basis. The Waterloo and Braden, I would anticipate, and Jamie and Jane can jump in, but I would anticipate that would be carried out by the health care professional.
Yeah, I would agree.
Okay, that's great. Thank you for
Yeah, me too. The simpler tools are probably much easier for your care staff to use.
Yeah. Okay. Any literature on how to assess and identify beginning stages of moisture pressure ulcers on all skin colours react to red may not always be applicable.
Yeah, I can see. Oh, sorry, Joyce, I was
yeah,
talking.
No, it's okay, Jamie. I'll let you take this one.
I can see one of our colleagues has added the skin tone bias documentation there as well. But if you go onto the Health Improvement Scotland website, where you can download the tools that go through the spotting different stages of change, it does also cover this as well. So they're worthwhile downloading.
That's great. Julie's saying the app is called Right Decisions if you're looking at through the App Store. Thank you, that's really helpful. And then Vicky's link there. Can we get a copy of the Pura or the 5 questions? I'll make sure that when the slides go out that we give you the links to these as well. And next question, in short breaks, respite, what would be advised around risk assessment and skin assessment? People coming from family home, perhaps only using service over the weekend. Jamie, you've probably got some experience around this. Would you mind taking that question?
So I think it's probably around about thinking what's in place for them at home. Has their risk changed because they've moved environment? We would always encourage reassessment at the point somebody changes environment or something changes in the environment. So it would be about that kind of managing that transition of care safely and thinking about what they need to keep them safe during that short stay.
That's great. Thank you very much. So there's no other questions in the chat. Is there anything last minute? Okay, so that's been a really helpful afternoon. Thank you very much. Jenny's just popped the evaluation form in the chat for us. So if people would be kind enough to take the time to complete that and give us some feedback, that would be really, really great. Thank you very much. Thank you to Jane and Jamie for their participation today and sharing their knowledge and experiences. We hope you've enjoyed the session. As I say, the slides will be coming out to you pretty soon. And if I can just plug the Stop the Pressure Ulcer Week again, the 13th to the 17th of November, and just to use their theme, please make every contact count for the people you care for. Thank you.